Voilà, c'est le lien YouTube.
D'accord.
Cyril,
Il y a tout le monde, docteur Perry.
Oui, professeur Deliba est là.
Ah, très bien.
Bonjour.
Calvin is here too.
David, oui, il est là. Il s'appelle...
Joao est là, il est venu. Mademoiselle.
دكتور حديث
Ouais, salut monsieur Doliba.
واش راك صافا؟
Ça va très bien, alhamdoulilah.
الحمد
Merci.
لله. Bon, écoute, je ne sais pas comment on va faire pour le morceler. L'anglais, hein, on va. Sinon, Thierry, tu te débrouilles bien en anglais.
Oui, oui, je peux, oui.
Oui, il n'y a pas de problème. Soit moi, soit Henry, ça va traduire.
Ah, très bien. On a les translateurs, donc.
Voilà.
Sans problème.
Ah, super. Très bien.
Ouais.
Enchanté. Ah, yeah. Ah, enchanté, can you hear me?
C'est où ça?
C'est derrière,
Hein?
c'est derrière.
C'est rien? Magnifique.
La côte algérienne.
Ah, ça se connaît.
C'est bon.
Ça se connaît bien. Ça aussi.
Hi, Shafik, can you hear me?
Hi, Calvin. Yeah, I can hear you. How are
Hi,
you?
hello, how are you?
I'm fine. How are you?
Fine, thank you. I just finished an operation.
Yeah, okay. How was your surgery?
Yeah, it's fine.
Yeah, okay. How was Hong Kong?
It's okay, it's okay. Bonjour, everyone.
Yeah, everything is okay right here.
Yeah,
Not too much
And-
surgery.
yeah, and yeah, everything is okay on your side?
Yeah, it's okay. Happy to see you. It's been a
Yeah.
while right now.
Yeah, it's been a while. They're really happy and honored to be invited by you to join
Yeah.
this section.
Yeah, thank you, Calvin.
So thanks. Welcome.
Bon. Professeur Gardner est là?
D'accord.
Non, je ne sais pas, justement. Non, pas encore.
C'est pas lui.
Ah non?
C'est pas lui.
Non, non. Professeur Berthy, bonjour. Le son, le son.
Non, non. Ici, j'ai le son là.
Ah oui, maintenant, je viens de rétablir.
Ouais.
Le professeur Gardner est là.
Ah, d'accord. Bah, très bien.
Welcome, Mr. Gardner.
Ouais.
Salut Halim.
There, I think I was muted.
Yeah.
Yes. Bonjour.
Bonjour. I think it's moment to start now.
Just go ahead and start. Okay. Well, good morning. Thank you for the invite, and it's good to see everyone.
Yeah.
I guess it's good afternoon, good evening there. I'm going to go ahead and share my screen. And I'm going to talk this morning about, are you able to see my, let me see here. Are you able to see my screen now? Okay, I'm going to talk this morning about what I see as the role of endoscopic endonasal surgery. I'm going to talk a bit about some technical aspects of the surgery itself, and then talk about some of the limitations and where things might be going in the future with endonasal surgery. So one of the key things to understand is that endoscopic approaches are different because the visualization device is different. We're using a microscope and the optical properties are simply different. With a microscope, here you have this view of a portico overlooking a bay. You can zoom in, you have a nice 3D view. You can get very magnified views, but the endoscope can actually enter into the surgical field. And by placing the endoscope into the field, you can have views, excuse me, that you just wouldn't have with the microscope. So here's a typical transeptal view for a transsphenoidal approach with a microscope. And just like with that view of the bay, if you place the endoscope into the field, you have a much wider view of the surgical field. The endoscopic endonasal approach is used always in this same fashion, at least the way we practice it and the way we believe it should be practiced, which is with two surgeons, ideally an ENT and a neurosurgeon working side by side. And with the endoscope in the 12 o'clock position, it's the famous two surgeon forehand technique where I can work and do bimanual dissection the same way I would if this were a very large open surgical approach. And so the key aspects of it, working with two surgeons, are that I have different goals than the ENT surgeon does. I want to expose and identify all of the key landmarks. I want to see the carotid artery, the optic, and I want to make sure I have enough working space to be able to do two-handed surgery. At the same time, the ENT surgeon is trying to preserve the anatomy and the function of the nose, which as a neurosurgeon, I'm simply less concerned with, and make sure that I have good reconstruction options. There are a number of modules of approaches, and in the sagittal plane, the midline, we can go everything from a transcribiform to a transclival, and I'll discuss those at least in brief. The cella, of course, is the center of the skull-base universe, and it's where we begin our approaches. Here, one of the key advantages of the endoscope is the ability to access the cavernous sinus, which is traditionally somewhat of a no-fly zone for microscopic surgery. The key to this is exposing the carotid artery. We can visualize it, but to take advantage of that, we have to be able to have the techniques to expose the carotid artery. So as opposed to just thinning and removing the bone over the cella, which is very thick in this acromegalic, the cella, of course, is this, and remove the bone over the carotid artery itself. So this is more like ENT or some of the transpetrous approaches where you have to be comfortable thinning the bone and eggshelling and blue lining bone over the carotid artery. And here you see the kerrison is used not as a biting instrument, but rather as the footplate to dissect the bone off and then carefully peel the bone away from the carotid artery. Here we can Doppler the artery so we're certain about its location. And by exposing the artery in this way, we can now work behind it. So now when I open the cella, it can open the dura widely. I can even open into the cavernous sinus. Here's a little hook blade that Mizuho made for us, which I can use to open into the cavernous sinus safely. And then I can see the carotid artery. I can see the medial cavernous wall. In this case, there's quite a bit of invasion of tumor, and so I have to carefully dissect the tumor from the medial cavernous carotid artery. Once I've dissected that plane, I can then go back and dissect the pseudocapsule with the gland. Again, the endoscope allows me to visualize the gland. I can debulk the tumor and send for specimen, but only after I've dissected those planes. And then finally resect the medial cavernous wall. And I'll talk a little more about which different ligaments we have to cut in order to resect this. But here's the final ligament being released. And then there's a little bit of involved cavernous sinus on the posterior aspect of the carotid artery there. Just cutting that free. Again, anything that's attached to an artery or nerve is sharply dissected. And here you can see the final defect, but it's that skeletonization of the carotid artery that allows us to work safely in the cavernous. Now, the transtuberculum or transplanum approach is a natural extension of a transcellular approach. And that was really the first extensions. Here's a view of the endoscope showing us all of the anatomy from the planum to the tuberculum, the cella, the clival recess, paracellar carotid artery, the optic nerve, the lateral OCR, and then what we call the medial OCR, which is sort of the keyhole for the endonasal craniotomy. This gives us access not only to the cella, but also the suprasellar space, the optic nerve, the carotid artery. And this is a key area of bone removal for suprasellar, especially tumors like craniopharyngiomas and meningiomas, because that is the main working space for the suprasellar approach. So here, removal of that bone of the medial OCR is really key. And this is the view that we get once we do that. And these fine vessels inside there are critical. These are the superior hypophyseal vessels, which are important for supply to both the chiasm, the optic nerves, as well as the pituitary gland and stalk. Now, suprasellar approaches, again, have these two key components, bone removal and then preservation of the superior hypophyseal artery perforators. Resection should follow the same principles as a microsurgical approach. We want to do internal debulking and then extracapsular dissection with countertraction and blunt and sharp dissection at all times. Following these principles, you can take advantage of the endoscopic approach without losing advantages of the microscopic approach. Now, retrochiasmatic tumors are one of the key things that you can access through an endonasal approach. But if you study here the anatomy of the infundibulum, so any tumor that arises from the hypothalamus and the infundibulum or the gland and extends upward, like a craniopharyngioma, for example, which all originate here, are technically all retrochiasmatic tumors. So every craniopharyngioma is retrochiasmatic. People call some of them prechiasmatic because they may herniate in front of the chiasm, and that can provide a working window for a craniotomy. But the truth is that they all originate in the retrochiasmatic space. So if you want to resect them and get to the origin of the tumor, you have to understand their retrochiasmatic. This provides some significant advantages for an endonasal approach for almost all craniopharyngiomas. It's a natural inline corridor. We can preserve stalk and hypothalamus, but we do have to be able to deal with CSF leak. This inline concept, this is the 2-point concept, I think popularized by Spetzler, where if you approach a tumor in its long axis, you have the widest axis to that tumor. With a craniopharyngioma, and here you see a very typical one, the endonasal approach really is the only option that gives you a true inline access. This is looking at a more recent study that we did from 2017, looking at almost 100 craniopharyngiomas. And here you can see we're able to get gross total resection in about half, and then near total resection more than 95%, and another 25%. And I'll show you how we improved at that over time. Now, early stalk identification is important for preservation. And I think the endoscope and the endonasal approach gives a unique ability to do that. If you look at this tumor, I think it's impossible to tell where the stalk is. I certainly could not tell on MRI, but as soon as we open into the suprasellar space, here you can see opening, again, that medial OCR bone has been removed. So I have wide access. We open the diaphragma. This is some ICG endoscopy that we use now that helps me identify fine vessels. And I can see this is clearly an avascular area in the middle, and there's no way that the stalk is located there. Here we can see a superior hypophyseal. I barely even have to see the chiasm. I know that the chiasm is above and in front of me because it's a craniopharyngioma. So I can directly access into the tumor itself. I can aspirate and open that cyst, and then I can start to follow the cyst wall. Now, these tumors, sort of like an acoustic neuroma, have an internal capsule to them. And if you get inside that internal capsule, it becomes much easier to preserve things like hypothalamus. But if you don't dissect the original arachnoid and even that second inner layer, then you won't get into the true tumor itself. So I find that if you follow that principle of understanding this inner capsule, again, very similar to a schwannoma, then you can follow the tumor right up. You can identify the hypothalamic margin quite nicely. Here you can see we're able to dissect it cleanly off of the hypothalamus. Those little calcifications do not need to be removed. Finally, trimming the last attachment on the hypothalamus. Again, that's all done under direct visualization. And here we can see that attachment on the back of the chiasm, and we can clearly see the stalk. And so I work my way toward the stalk. Here we're cutting out the involved floor of the third ventricle directly off the back of the optic chiasm. But that ability to place the endoscope into the surgical field allows me to follow these planes. And in this case, I can preserve the stalk. I leave a little bit of thickened capsule there, but in a patient who wants to preserve their stalk function, I think this is important. This does have slightly higher risk of potential regrowth in case there's some tumor in this capsule, but you can see this is largely inflammatory capsule here. Here's our view at the very end, and we have a complete removal and preservation of the stalk. Of course, a nasal septal flap at the end, along with an inlay of collagen. So here we're able to preserve the stalk and the function in this patient, and I think without an endoscope, I would have not been able to do that. If you look at our series, the patients who had intact function, we're able to maintain that function in about a third of them. Again, not perfect record, but I think if you don't try, you won't be able to help even those patients. And then patients who had some dysfunction, we're actually able to improve some or maintain the function that they did have in the majority of those. The same holds true for diabetes insipidus. We're able to avoid that in about 45% of patients, which is a pretty dramatic impact on quality of life. Perhaps the most critical margin, though, is the hypothalamic margin. This is what can lead to a patient having a very poor outcome after surgery. Here's a craniopharyngioma that had been treated with intracystic radiation in the form of P32. We see some edema in the hypothalamus and that T2 on the bottom right corner. And this is one of the advantages, is the third ventricle and the hypothalamic margin is much better visualized. Here's a very wide opening, didn't necessarily need to open all the way up to visualize the optic chiasm. because we know that the chiasm's up here, but this gives a much wider exposure and ability to visualize that hypothalamus. So in this case, I maybe would have opened a little bit lower ideally and still had the same view, but this does give more room for the endoscope. You can see here, the stalk is involved and the whole hypothalamus is the origin of this tumor at the floor of the third ventricle. But with a craniotomy, I would not get this subchiasmatic, this retrochiasmatic view that allows me to dissect the hypothalamus. Here's a dissection of the hypothalamus. I believe this is Dr. Fernandez Miranda doing this particular dissection. And here we can see dissecting, again, off the posterior aspect of the chiasm, but my ability to visualize that, the only limitation then is my microsurgical ability with the endoscope to be able to define that plane. And we can see normal and abnormal. You can see this grayish abnormal tumor versus the normal chiasm and hypothalamus. And you can really distinguish it and you can decide exactly how aggressive you want to be with that margin. If this is a sicker, older patient, maybe you just debulk the tumor and leave that margin. But in younger patients, I tend to be more aggressive because this is our best chance at resection. As we resect the posterior aspect, you can see all the structures behind the membrane of Lilliquist, including the third nerve and the PCA and SCA. And then the final view here, you can see exactly where that attachment is with the hypothalamus, and that can be carefully dissected free. And here's our final view. And we can decide how aggressive to be with this hypothalamic margin or not, depending on tumor involvement. And here's the post-op showing a complete resection. And vision is one marker of how carefully we dissect this with a higher rate of complete removal. And again, we had no cases of permanent worsening with craniopharyngioma. So what are the limitations? Well, I think a purely interventricular tumor, if there's a poor margin, it doesn't matter what approach you take. And then I'll talk a little bit about calcified tumors. Here's a multiply recurrent pediatric tumor, very heavily calcified. And I would challenge that regardless of the approach, this is almost impossible to deal with. Endonasally, we have the same toys and tools. Here's a Sonopet bone cutting tip that can be used to break apart a calcified craniopharyngioma. You can see a catheter that had been placed before. We can see how stuck this is to the basilar artery. And I can even have to stabilize the tumor and try to drill. So these calcified remnants are almost impossible no matter what approach we take, but we do have the same ability to deal with it at least as well as possible endonasally as we do open. Here's the final view. We can see how stuck this is to the basilar. There's just no way to completely get that off safely, but we're able to get a pretty decent resection of this tumor, leaving some of that calcified portion that's completely adherent to the basilar. Another limitation is the floor of the third ventricle, so purely interventricular tumors. If you look at this tumor on the left here, here is the midbrain. So this is actually growing below the floor of the third and pushing the floor of the third up. You can see how this is decreased here, it's being pushed up, and the angle between the midbrain and the pons is an obtuse or an open angle. Whereas in this purely interventricular tumor, if you look at the coronal, there's not much difference. There is some hydrocephalus, but the angle, the midbrain is not pushed up. Instead, the midbrain is pushed down. So this becomes an acute angle here, which tells me that this is actually in the third ventricle. My space between the chiasm and the pituitary gland is almost non-existent. And this might be better for a transcranial, perhaps an interhemispheric approach, which is what I did for this particular tumor. So these are, again, I think the advantages for an endonasal approach for craniopharyngioma, but of course, CSF leak remains a little bit of a limitation. Suprasellar meningioma is the next other natural tumor to access here, and this is perhaps a little more controversial. Here's a classic tuberculum meningioma with bitemporal vision loss. And even more importantly, here is a wide bony removal, and you can see here the tuberculum itself and the dura behind the tuberculum is involved with tumor. This is the origin of the tumor. That ability to remove all of this bone up front gives us a better ability to do a Simpson grade 1 removal. The dura here clearly is thickened and involved. I would challenge that removing tuberculum dura like this that extends down into the sella from, for example, a terional approach is essentially impossible. You can coagulate it, you can scrape it, but you can't resect that tuberculum dura right down to the diaphragma. You'll notice here, this is not a soft suctionable tumor. So there's very careful debulking of the tumor using scissors. There are different, you can certainly use ultrasonic aspirators or this Myriad device. And we're dissecting very carefully around the tumor. Again, the idea here is you're working from the inside out. So I'll debulk the tumor and then I'll identify one optic nerve or one carotid artery. And then I know if I follow the optic across the chiasm to the other side, I know exactly where the other optic is, and then I can connect between and dissect the anterior cerebrals last. So here's just showing after the final dissection, I can peel the tumor out. We can see the attachment here on the right medial optic canal. Again, dura that's virtually impossible to see or remove from a transcranial approach unless you did a big subfrontal approach. And I can resect or coagulate that last bit of dura to get as close to a Simpson grade 1 resection as possible. Here's the final view, and then I do a collagen inlay followed by nasal septal flap on top of this. Here's the post-op with improvement in the visual field. Again, these are the advantages that I see for suprasellar meningiomas. I'll use our early meningioma series to try to demonstrate some of the advantages of this. This was 75 patients. Again, our very early outcomes, but I think really quite good even early on. Visual loss is about 80% of patients present with visual loss, a very common presenting symptom. And if you look at even this early series, we were able to get a Simpson grade 1 removal in almost 80% of cases. And this is not hyper-selecting cases. This is essentially any tumor that we think we can resect endonasally, we tried to do. Again, the majority of the rest even underwent near total resection. There's an early devascularization and a lower Simpson grade 1 resection. I talked about that briefly. And there may be improved vision outcomes if you look at endonasal approach. So vision was improved or normalized in almost 86% of cases, very similar to craniopharyngiomas. And it only deteriorated in about less than 4% of cases. If you compare this to craniotomy studies, this is very favorable numbers. There have been a number of systematic reviews done that have confirmed this. Obviously, there's some selection bias, but really not very much at all. Essentially, all suprasellar meningiomas at our institution, unless they really involve the clinoid significantly, have been done endonasally. What about limitations? What are the lateral extension limitations? Well, ear, nose, and throat doctors know that you can access the entire medial optic canal and orbital apex through an endonasal approach for decompression for trauma, for example. And this has become part of our bone removal. Much as you would decompress the optic canal during an open approach, you would do the same thing endonasally for a meningioma. This allows me to have wide access to the optic canals. It gets early decompression of the optic and allows me to dissect safely between the optic and the carotid. Now, you don't want to open below the optic canal because that's where the ophthalmic artery lies and where the carotid artery lies. So when we open, we want to open at the upper limit towards the falciform ligament at the upper optic canal. Extension into the optic canals in our studies was not a limitation for gross total resection. So what things were? Well, very large tumors, multilobulated tumors, so that suggests subarachnoid invasion, and then vascular encasement, and this is a challenge regardless of approach. Vascular dissection may be more difficult. It's part of the learning curve, and understanding that's important. So if you have a tumor that has a nice cortical cuff, this is easy. There's no vascular dissection. As soon as there's vascular contact or adherence, you have to worry about your ability to dissect the vasculature. And this is something that is gained over time. And then finally, vascular encasement. And I can successfully and safely resect tumors with vascular encasement. But here's an example of the dangers that you face. I had an injury to an A2 here and ended up with a Hoydner infarct in this patient after resecting this suprasellar meningioma. There is, of course, a learning curve. Here you see even over our first 75 patients in the dark gray, you can see improvement in the gross total resection rates over time. And you'll see that in every single tumor I show. So we're essentially able to resect 90% with gross total resection. Part of that learning curve is understanding this wide bone removal to get a Simpson grade 1 resection, and also wide intradural dissection. CSF leak is the trade-off here. In the pre-flap era, it was really extraordinarily high, and now it's probably down to less, now around 7%. which is getting close to modern craniotomy studies, but still a higher leak rate. Now, this does also avoid brain exposure and manipulation. We had no patient with contusions, hemorrhage, or seizures, and I'll talk a little more about seizures in a moment. Now, the transcribiform approach for olfactory tumors is a little more controversial, perhaps even. The same considerations with vascular involvement come into play. So when a tumor extends into the cribriform, vascular involvement or vascular dissection also is something that has to be understood. But these are what I view as the advantages. This is even more controversial perhaps, but relatively medium to large, but not giant tumors. And then we get very direct access to the base of the tumor. If I showed you this particular convexity meningioma, nobody here would question what the approach is to come from above. However, the tumor base of this tumor, this is exactly the same tumor, I would argue, only turned upside down on the skull base. If you view it in that same fashion, the obvious approach to this is through the ethmoid sinuses and through the cribriform. Here's a view of the cribriform plates from above, and here's the same view from below, directly through the ethmoidal sinuses, and this gives us access to the involved bone, as well as the vasculature that feeds this tumor. So we can do early tumor devascularization. You can cut the ethmoidal arteries and coagulate them. And here's an example of an ideal case for a transcribiform approach. It's an older patient. You can see the bony involvement at the base. You can see some separation, so there's not vascular contact, and he's already anosmic. And here's the post-op after resection from an endonasal approach. Another advantage is improved visualization of the posterior margin. You can access the posterior margin very early. From an open approach, here you can see it's one of the last things we see is the posterior margin in the chiasm, regardless of the approach. Whereas coming from below, we can go directly back to the posterior margin, dissect the chiasm and the anterior cerebral arteries very early on. Again, looking at our early olfactory groove series, we can compare and look at primary and recurrent tumors, et cetera. The mean tumor diameter here you see is about 4 centimeters, so that's pretty typical. The very large tumors, we might have staged these tumors, so they might have been broken down into 2. Here you see complete tumor resection, Simpson grade 1, not just a gross total resection, but a Simpson grade 1 was achieved in 2/3 of patients, and the rest essentially had near total resection. So very good rates of removal. Lateral extent of resection. If you see a very large tumor like this, so this tumor we decided to stage. I did the initial tumor debulking. There was significant frontal lobe edema. You can see after initial staging, the edema has completely resolved, but also interestingly, as the tumor collapses in, it becomes very obvious that this tumor out by the orbital apex was not actually dural attachment or a dural tail, but simply the tumor billowing out towards those edges, and the actual attachment was very narrow, and then I was able to get a complete resection in the second stage. Well, limitations again are size, so larger than 4 centimeters, we only got 50% of them gross total resection, so the larger they get, the less likely. Very calcified tumors were harder to get them to deliver down. And then, of course, absence of a cortical cuff, which correlates with size, and also vascular involvement. So I do think that less than size, it's anatomic limitations. Here we looked at 100 tumors. This is both cribriform, planum, and tuberculum tumors, and found that these are the locations where we left residual. And they're sort of obvious, perhaps, but they're very clear anatomic locations. So in the top left here, you see the lateral aspect of the orbit, so past the mid-orbit, where we'd have to be reaching beyond and stretching the optic canal. You can remove the lamina papricia and displace the orbital contents to access tumor all the way out to the mid-orbit, but you can't get beyond that. And then tumor that's on the other side of the clinoid. This includes other side of the optic nerve and canal, rather. This is the supralateral compartment of the optic canal and the anterior clinoid itself. And then finally, reaching upward, we can only go so far up the falx, and then we leave residual behind. So these really are the anatomic limitations, and you can see them represented in this CT as well as this figure drawn here. I think it's important to understand these. They may be obvious, but I think really stating them helps to understand tumor selection. The golden rule is don't cross the nerve, and that's why we end up leaving tumor lateral to the optic nerve. So these are cases that would require either an eyebrow craniotomy or a standard terional approach. And these are cases I would do open, where the tumor is clearly lateral to the optic canal or lateral or invades or involves the carotid very widely. And these are cases I would do endonasally. Even this one, which on the left, which appears to billow over the carotid artery, is still displacing the optic nerve upward, and so we can access it. And these are cases where I'm not sure. Very large tumors, we did this endonasally, but there are tumors with meningiomatosis that may require multiple approaches. And then there are tumors where the relationship to the optic is very difficult to determine. Here's an interesting case with a tumor that extends very far over the left optic canal here. And this woman has chronic left eye vision blurring. It's her primary symptom. I know that with an endonasal approach, I have better visual outcomes. So that's why I chose an endonasal approach for this, with an understanding that I might leave some tumor laterally. I even did a Fiesta image to try to understand the relationship of the optic, and you couldn't really see the optic well. And so I knew that I thought this had to be displaced laterally. And it turned out that the optic was pretty dramatically displaced in this case. So here you see I'm opening into the optic canal. Again, I don't open the lower limit of the canal because I can injure the carotid there. Here I'm dissecting the diaphragma. I identify the right optic nerve because that one is going to be easier to identify because it's not as involved with tumor. And then dissecting carefully those suprahypophyseal branches and the pituitary stalk. You can see there aren't just beautiful planes. It's not a soft tumor that just falls out, so I have to be very careful. Then finally dissecting on that left side, I finally see the left optic nerve. This tumor has really extended dramatically and pushed the left optic nerve upward. It's a wonder she has any vision left whatsoever in this eye. Here's working with an angled endoscope, doing very careful, sharp dissection, visualizing the optic, cutting any attachments, debulking the tumor with 2 suctions so it's not too heavy as I try to peel it off of the nerve. And I'm working here between the optic nerve and the carotid artery. Now there's nothing between the two except for laterally where the ophthalmic artery is. Then I go back and dissect the suprahypophyseal. And I'll skip forward in the interest of time, but you can see in the end, I was able to dissect all of this tumor because it actually had pushed the optic laterally. Now that's perhaps somewhat luck, but look at the space the tumor has made between the carotid and the optic. By following the tumor corridor, I can dissect all the way out to the ICA bifurcation. I can get a complete resection of this tumor. But I chose this approach because of the vision, and it turned out to get me a good advantage and really get a complete resection of the tumor. There's just visualizing with ICG to ensure I've preserved all the vessels. And here's the immediate post-op, which shows what appears to be a gross total resection, just a little bit of blood in the tumor cavity up top. Reconstruction options are limited, and so we end up with high rates of CSF leak with a cribriform approach, especially. But if you look at the radical transbasal approach, the downside to this is inevitably we resect the dura and leave a wide opening, and that leads to high CSF leak rates. We've managed to get this down to about 10%, but it's still higher. And here you can see that same learning curve where we have increased gross total resection rates over time and a decrease in CSF leak rates. This does avoid any brain retraction and manipulation, and mental status is improved in essentially all of these patients or normalized, and vision also same kind of thing for the cribriform tumors. Now, following, here we see the same access. Well, you might say, well, why endonasal surgery? Why do this if we have a nice approach, we can do an open approach. I know it can resect this. Well, there's no frontal lobe manipulation, and I think this has a real potential advantage. When we looked at equally matched tumors done from an open approach at a skull-based center compared with an endonasal approach at a skull-based center, the difference in MRI or radiographic changes on the postoperative scan was dramatically different on an endonasal approach. So we had less radiographic impact on the frontal lobes. And so I can't prove that this makes a difference in frontal lobe function. And certainly many of us neurosurgeons don't use our frontal lobes. But I do think that trying to preserve this can make a big difference. I don't know if this has neurocognitive consequences, but I have to believe that those frontal lobe changes impact the patient's overall neurocognitive outcome. In addition, if you look at the impact of brain retraction on seizure, we reviewed endonasal versus open approaches in our own facility for extraaxial tumors over the same time period. Similar locations of tumors. The patients undergoing endonasal surgery only had a 1% risk of seizure, whereas those with open surgery had a 3% risk, and they were even treated with prophylactic anticonvulsants. So these are the advantages I see for the transcribiform approach, but naturally you have to be comfortable working as a team and doing microsurgical dissection. This drives us down now to the clival approach. Now the clivus itself, I think, is a very natural access. You can see it's very direct. Transnasal access doesn't require angled endoscopes for the most part at all. And here are the advantages I see for the posterior fossa endonasal approach. It's a very direct midline approach. When you expose the nasopharynx and do a sphenoidotomy, we automatically have access to the entire clivus. This is great for midline tumors. Here you see an example of a clival chordoma, classic clival chordoma involving the mid and upper clivus. And we can get really a very radical removal of this because of how direct the approach is. I want to emphasize here, this is not like a pituitary tumor where you might just core it out and perhaps try to reach with a suction around the edges, but this is a tumor where we want to remove any involved bone with a wide margin. So we've drilled even a good 0.5 centimeter to 1 centimeter below. I'm going to do what we call a pituitary transposition, where I open the cavernous sinus between the sella here on, and the carotid artery. And this allows me to dissect out the posterior clinoids. This is a so-called interdural transposition. And this dissection of the clinoid allows me to make sure I get a wide bony margin at the superior clivus. We looked at this in chordomas and found that in clival chordomas, when we resected the posterior clinoid, situations like this where it wasn't obviously tumor, we had tumor involvement in almost 80% of cases. So 80% of the time, this posterior clinoid is going to be involved with a chordoma that it comes near to it, so it really needs to be removed. Here you see that interdural pituitary transposition and removal of the posterior clinoid. So wide bony margin. Then finally, I can dissect out the tumor. These tumors are usually interdural, so between two layers of dura, between the outer periosteal layer and this inner meningeal layer, which you see it being dissected free from. There we see that inner meningeal layer, and the tumor's dissected free from that meningeal layer. Now you can see the tumor involving that inner layer, and the only way I can get a complete removal of this tumor is to resect that meningeal layer. So we'll open that, we'll remove that inner layer. You can't be afraid of CSF leak if you want to try to cure or get a radical removal of these tumors, because removing that inner dura really makes a difference if it's involved. If it's not involved, I don't remove it, but if it is, then you really have to. Here we see the 6th nerve on the left side, and I can remove dura right up to Dorello's canal. And then removing further dura, we find more tumor nodule in the interdural space. So again, this radical removal of all involved dura and bone can't be emphasized enough, or you will leave residual tumor behind. This complete removal gives us much better outcomes. And here we see the final result with a radical removal, nasal septal flap, and a multi-layer reconstruction. Again, we've gone to 3 layers of reconstruction for transclival. I'll talk about that in a moment. Here we see a complete removal of this tumor. Again, our experience up to 2015, I think now we have well over 200, probably close to 250 chordoma surgeries, able to get complete resection for primary tumors in almost 75%. Much higher rates of gross total resection for primary tumors than for recurrent. And again, endonasal approach is not the only approach to the skull base. It is only one approach. And even in our hands, 11% of these required combination with an open approach. The most important thing for a chordoma is a complete removal, regardless of what approach it takes you to get. The endonasal is a workhorse for them, but it can't be used by itself. This direct access and visualization gives us decreased cranial nerve morbidity. And you can see here, new cranial nerve deterioration is only 5% in primary tumors, permanent. That's really quite good. If you compare that to literature, that's one of the key advantages of this midline approach, is decreased cranial nerve morbidity, because we're only reaching the cranial nerves at the very end. These are almost all 6 nerve limitations. The lateral and inferior limitations are the carotid artery. We found over time what affects gross total resection is these tumors that are lower lateral. The lower they get and the more lateral they get, the more challenging they get. But we also find that over time, we got better at resecting these. This is partly understanding. Here you can see again, learning curve. I can't emphasize this enough. This is our first 60 cases, pretty dramatic learning curve, before we could get complete removal in almost all of these tumors. And this was one of the areas we didn't understand well. This is a Roten image, and you can see here, it's all very intuitive to resect between the carotid arteries at the upper and mid clivus, but the lower clivus and the craniocervical junction, our limitation actually is dramatically more lateral, especially if we lateralize or even transect the eustachian tube, we can resect all the way out to the medial condyle. So by not crossing nerves, now we can get all the way out to the hypoglossal canal. Here's a chordoma resected through what I call a far medial approach because it's sort of the opposite of a far lateral. You can see tumor coming right up to the jugular foramen and the inferior petrosal sinus. Craniocervical junction tumor. You can again see that jugular tubercle is involved. I can remove this though right up to that inferior petrosal sinus. As soon as I see bleeding from that sinus, I know I've gotten complete removal. I've uncorked that sinus. Now my only limitation becomes the hypoglossal canal. So I've completely removed all involved bone. Here's the hypoglossal canal. Here's the medial jugular tubercle. Here's the medial occipital condyle. A real radical bone removal on both sides. And then you can see here, wide bone removal, much wider at the inferior and lateral margins below the paraclival carotid artery, and preservation of the hypoglossal nerve. This can also be used for tumors like this epidermoid tumor. You can see dramatic impaction of the pons here. There's really no other approach that gives me access to the mid pons. This is a very direct approach. I can very carefully tease this tumor out of the pons. I can see the basilar. I can see any long and short perforators off of the basilar. I can tease the tumor out. And when I'm done, I have this beautiful view with a near complete removal of an epidermoid. Of course, this extensive epidermoid, you're never going to get 100% removal of. It's simply not possible, but a very nice resection and a beautiful post-op scan with great relaxation of the pons. And you can see the pons in a much more normal position. There's a higher risk of CSF leak than other locations in the posterior fossa. This is true for open and endonasal approaches. It's also true if you look at the chordoma series and compare it, no matter what approach you do, if you get a radical removal of a chordoma, CSF leak rates are high. What's our inferior limitation? Well, the odontoid. We first described this back in 2005, endonasal odontoid resection. And how low can you get? Well, if you draw a line on a mid-sagittal CT scan all the way from the bony nasal bridge to the hard palate and extend it into the depth, this can predict approximately how low you can get. The indications are really the same. So irreducible bony compression. If you have progressive compression, here you see after prior fusion, there's a significant bony mass that needs to be relieved. So that can be done endonasally. And if there's significant pannus, and you want to do a posterior fusion afterwards, I will also decompress this because I think we can do this safely endonasally. Here's progression after a Chiari with significant basilar invagination 20 years after Chiari surgery. And the beauty of this approach is it's very direct. Right between the eustachian tubes, I can preserve the nasal septal flap pedicle. Now we will do a little U-shaped flap, so we separate the oropharynx, but you can also just resect the nasopharyngeal tissues. But we do a little U-shaped flap, push it down towards the oropharynx, and then here you see me drilling the anterior ring of C1, exposing the C1-2 joint, resecting the joint capsule. And this is just to show also how deep this is, but also this is one of the tricks and tips of odontoid. You have to drill this maxillary crest right here where the nasal septum meets the hard palate. There's a little maxillary crest. If you don't drill that down, you won't have access as low as possible. That bone will limit your inferior access. So that's very important tip to make sure we have access all the way down to the base of the dens. And then the technique is really the same whether you're doing this through a transoral approach or transnasal. You want to drill from the top down so that you don't disconnect the neck of the odontoid and have a free-floating peg of the odontoid with all the ligamentous attachments. So we remove from the top down, remove the ligaments. Now, if there's no pannus, I'll just resect up until I see the pulsatile tectorial membrane. If there's pannus, it's really the same goal, although the membrane cannot be as obvious. And you just want to see pulsations like you see here, with a very wide decompression all the way out into the lateral mass of C1 on either side. We are fortunate to have intraop CT to double check this, but you can see a nice low and lateral removal. Well, what are the advantages of endonasal over a transoral approach? Well, patients can be fed immediately. There's no oral incision. There's no velopalatal contact, so they can be fed immediately. Here you can see the soft, this marked in red, the soft palate contact point. All of our surgery is above this, so we don't create what's called velopalatal insufficiency, where you can get regurgitation or a nasal airway. And so we don't have any contact or conflict there. Again, looking at our series of patients, significant learning curve. We got much faster over time. Now it takes us about 2 to 3 hours to do odontoid, where originally it took even up to 8 hours. This was successful in all patients, and nobody else required further craniocervical junction decompression. Now, the biggest fear, of course, is vascular control. Is this really a limitation? Here's an example of a giant PCA aneurysm presented in a physician with a third nerve palsy. He was offered coiling versus clipping, and he elected to have clipping because we thought it would give better resolution of his third nerve palsy. And this is just to demonstrate sort of the extreme of the kind of vascular control you can have. We've done a complete clival resection here. Opening up the one trick here is I'll peel out the outer layer of the periosteal dura so that I've dealt with the interdural plexus. And then I can open the intermeningeal layer of dura in a very clean fashion. I don't get a lot of subarachnoid hemorrhage. It keeps my field very clean and clear. Wide removal and wide opening of dura. Now I can see, look how heavy and both large and also calcified this aneurysm is. I can't place a clip because of the weight of the aneurysm. So the only thing I can do here is to trap the aneurysm. You see there's basically no PCOM on the left side. So if I trap the basilar and the right P1, which does have a PCOM, I've essentially trapped this aneurysm. So here's the aneurysm trapped now. So now it's completely deflated. I've given the patient some burst suppression during this trapping period. And then I can place an initial clip that decompresses the third nerve, gets me across the aneurysm. Now I can remove those clips, I can reperfuse, and now I have control over the neck of this aneurysm, and I can more carefully dissect perforators, and I can place other clips as close as I want to. You can see how thick this atherosclerotic wall is. If I place a clip too close, I'll kink off the SCA or the PCA. A couple of clips to bolster given the size of the aneurysm, and making sure those clips don't kink the SCA, which they did very easily. And here's the post-op angiogram showing a complete treatment with preservation of both the PCA here and the SCA there. Here's a very large chordoma in which we had a carotid artery injury. This can be very challenging to manage. You can see how involved this carotid is, but this was a simple injury. Here's the sella, here's the clivus. We didn't quite have a transpterygoid approach. And for proximal control of this chordoma, we had done a small incision in the neck. Because this was a child, I didn't feel like I had good access for proximal control. So we'd done a small cut down. And unfortunately, then I cut directly, it looks like this video is not going to play, cut directly into the paraclival carotid artery here, unfortunately. And so I had to pack that off. I ended up sacrificing it with a bipolar because when we clipped it in the neck and dropped the blood pressure, the patient had great backfill and had no change in their neurophysiology. So I thought I could safely sacrifice the artery. We sacrificed it. And indeed, I couldn't have sutured it or anything. I could have maybe packed it off. The child had a persistent trigeminal artery as well as good crossfill. So luckily had no consequence from this. Vascular injury is a concern and a limitation, but fortunately it's very infrequent if you use proper technique. You can see 7 injuries over our first 2,000 cases, and it's spread really across, but you see chondroid tumors, chordomas and chondrosarcomas are probably the highest. We usually are not able to preserve the carotid, unfortunately, but fortunately there were no neurologic sequelae. The truth is, if you sacrifice a carotid, the chance of a stroke is probably only around 20 to 25%. Suturing is a huge limitation. You can't really suture endonasally. I wish we could. We've certainly tried, but it's very limited. This is our carotid artery injury algorithm. And essentially what it comes down, if you look at the middle window here, is if it's a very small injury, 2 to 3 millimeters, you can try to salvage it. But if it's a larger one, just pack it off and get the patient to your endovascular colleagues. They can have a lot of techniques from sacrificing to flow diverters to try to preserve the artery if you think it's necessary. Certainly you could do a balloon test if the artery bleeding is passed off. In addition to vascular, there are anatomic limitations. Understanding these anatomic limitations is very important. It's largely nerves and arteries. We obviously can't get much higher than the anterior wall of the frontal sinus. We can't get beyond the orbit, and we can't get beyond the optic nerves, can't get beyond Dorello's canal, and we can't get beyond the carotid artery. CSF leak is really no longer a limitation. Here we see a case where we're going all the way up into the third ventricle, so wide openings even into the ventricle. We tried everything initially. We had very high CSF leak rates. We discovered packing with balloons and a buttress with a balloon you see here being inflated. A Foley balloon works very nicely for some of these defects. And just using these techniques, we got a little bit better, but still had very high CSF leak rates. Vascularized flaps really are the key advance here. Very important. This was the same for open approaches. Open approaches had horrific leak rates until pericranial flaps were introduced. The same thing holds true for the nasal septal flap. You need vascularized tissue. You need a multi-layer reconstruction. Here's a picture of myself with Drs. Haddad and Basagastegui, who developed the nasal septal flap that Dr. Crow and then Dr. Schneiderman brought to us. And this has been really very important and groundbreaking and changed how we managed endonasal surgery by doing vascularized reconstruction. Immediately dropped the rates down to about 5%. And we've managed to keep them here. You see for pituitary adenoma, it's less than 3%. Here you see for meningiomas, we now have it down to about 7% for meningiomas. For chordomas, the leak rate, 20%, now down to about 10%. And here you see those leak rates dropping. And everywhere you see these dramatic drops, it's when we started using vascularized reconstruction. We still manage, there's still a learning curve to this day. We track our CSF leak rates every single year. We track them every single month. And here you can see we've gradually getting them lower and lower, trying to get them below that magical 5% mark. And these are for only intradural cases. So this is not all tumors. This is only tumors with wide intradural approach. So to summarize all this, I think endoscopic approaches have a learning curve that's both technical, so learning your technique and working together with two surgeons, and also anatomic. Understanding the anatomy from an endonasal approach really takes quite a bit of time. This learning curve has to be respected to maintain your outcomes. Here's looking at our careful use in Pittsburgh with endonasal versus craniotomy and how it took 10 years to get where endonasal had a shared space with craniotomy. Increasing complexity over the years. These are the levels that we've put forth as for training levels. Everything from simple sinus surgery all the way up to vascular surgery. I think most teams probably can and should stop around level 3 or level 4. The complication rates go up dramatically after level 3. Here you can see that. This is looking at our own cases over the last couple of years, looking at levels 2, 3, 4, and 5. And you can see the level 5 approaches look at things like blood loss, the length of surgery, how long the patient stays in the hospital. It goes up dramatically between level 2 and level 3. So these are clearly more complicated cases. Respecting this learning curve is critical. Again, the basic principles are bimanual dissection. I need both my hands to be able to accomplish the same things I would with open microsurgery. The resection has to follow the same microsurgical dissection techniques it would if this were a big open approach. And the reconstruction has got to include multi-layer with vascularized reconstruction. In the end, the patient selection depends on the corridor. It depends on the particular patient, what their needs and desires are, what their deficits are, and what your experience as a surgeon is. You have to respect all of these when you select, and that will change over time. These were developed as a cross-fertilization between specialties, and I think they're best applied by a multi-specialty team. You have rhinologist, ENT, You have a neurosurgeon who does vascular surgery and skull base. And this combination together has created this new specialty where we do endoscopic endonasal skull-based surgery. There's the rise and the fall of any surgical technique, and craniotomy is not falling by any means. It's very much a standard part of our treatment, but endonasal surgery is finding its place within standard skull-based and neurosurgery. I want to invite everyone, of course, always to Pittsburgh right now. Naturally, unfortunately, we cannot travel. We're working to put together virtual courses. If you have interest in a virtual course, please let us know. We're trying to get these set up and then figure out the best way to make this work for everyone and to continue our teaching mission. I also want to make sure everyone is a member of Skull-Based Congress. This is a free educational website that we pay for, that we host. It's designed to be a skull-based congress of sorts. It's designed to be really a blog, a community where we can all look at anatomy, we can discuss cases. There are all kinds of things on here, from blogs from Dr. Schneiderman about how to drive an endoscope, to anatomic lessons, to case discussions. And I encourage people to submit cases for the Skull-Based Congress, and also to join the community, and feel free to comment on cases that we put online. Thank you again for the invite. And it's wonderful to be able to at least see some friendly faces, even if it's not in person. And hopefully we'll get to meet again in person soon.
Thank you, Professor Gardner, for your excellent presentation. First of all, welcome to all the attendees, and some words from Professor Souad Barti. She is the president for the Algerian Society of Neurosurgery. Souad Barti.
Yes, thank you. So good afternoon and good morning in America. Just few words in the name of Algerian Society to, first of all, congratulate the Department of Neurosurgery of Lemine de Barine in Algiers for this wonderful webinar that they have organized. And also to thank all the participants and the speakers in this webinar, particularly Professor Paul Gardner. And so this is the first experience with a Department of Neurosurgery in collaboration with the Algerian Society, and they have organized a very beautiful program. And I think that we will move to the presentations and after to the discussion. So thank you for all the participants.
So Dr. Handis, would you please introduce the speakers? And after, we will proceed to clinical cases, and at the end, the questions and answers at the end of the session. Thank you. Handis. Audio. Attends, audio d'abord.
Hello?
Oui, it's okay.
Okay.
Can't hear you, Handis.
Yeah, we'll start. The case, okay?
Yeah. Yeah, you can speak. You have the floor.
Yeah. Can you see my screen?
Yeah, yeah.
Yes.
Okay. Hello, everyone, and I'm very happy to be a part of this webinar. And I want to say thanks to all the guys who helped to prepare this webinar, the president and the executive members of the Algerian Society of Neurosurgery. I want to say thank you to all my friends, Calvin, Mac, and Joao, Paulo Almeida, who are going to present just clinical cases after me. So my full name is Handis Shafiq, and I am a neurosurgeon from the Department of Neurosurgery under the supervision of Professor Abdel Halim Mosli. So just to show my case, our case is about a female aged of 32 years. So she had as past medical history, diabetes and hyper blood pressure. So she presented, it's been several years, a visual decline. Clinically, she was complaining mainly of headache. She had also kind of soft tissue swelling and enlargement of extremities. it's a phasis of acromegaly. We noticed also visual deterioration on the right side, but to 2/10. The left side was quite okay. Hormonal assessment found an important level of growth hormone factors. T2 sequences are showing this important macroadenoma. The cella is completely filled up, enlarged, with the extension of the lesion, as we can see to the left, to the right cavernous sinus. From a perspective endoscopic view, we can see that the whole compartments of the cavernous sinus are filled up by tumor. The superior here, inferior, and even posterior compartment of the cavernous sinus. It got also an important extension to the retroclival region. We can see well this midline just behind the cella extension of the adenoma, and probably the basilar trunk is completely engulfed by tumor. Another interesting extension of the lesion is just medial to the ancus. So most probably it left the cavernous sinus through the oculomotor triangle. So these sequences showing also the important encasement of vascular access, especially the superior cerebellar artery on the right side. So it looks like a very complex lesion with several extensions. Let's keep it simple. What are the limits of the surgical exposure? I mean, the bony approach and even the dural opening. Is there a special way to open the dura in these cases? And is there, just asking Dr. Gardner, is there some consideration on this specific complex lesion to resect tumor? Is there a trick behind the resection, the order of resection of tumor? And to finish, is it worth to do a pituitary transposition in this case? Thank you.
Yeah, good questions. I think the biggest considerations are that you can't have a wide enough exposure here. You know, because of how tall the tumor goes, you would have to do at least transtuberculum, if not more, and that's be able to work through the oculomotor triangle. You would have to remove bone all the way out to the middle fossa up to the orbit. You would have to decompress the optic all the way out to the optic strut. You would have to remove bone right up to Meckel's cave because the tumor goes in that lateral cavernous sinus. And then also to try to follow tumor through the oculomotor triangle, you would have to do that wide of a decompression, be able to work around the carotid artery. The order of resection is, I would just start with the cella. The reason you would be able to avoid, largely a pituitary transposition is because the tumor itself has done it mostly for you. So I would actually start in the cella. I would define the medial cavernous sinus on that right side. I'd resect the rest of the tumor within the cella. And then I would open the right cavernous. There is tumor in this case. If you go back to the pictures, there's tumor in the anterior margin or the anterior compartment of the cavernous, what we call it. And if you look at the anterior compartment, you can open safely into the anterior compartment because there's tumor between the dura and the carotid artery. There's another picture there. Yeah, so here you can see right there, there's tumor between the carotid artery and the anterior dura. So that gives us a window to sort of open into the cavernous sinus. There, right there, you see tumor. Now, obviously up at the distal dural ring, there's not tumor there, but lower down in that anterior inferior compartment right there, you can see there's tumor between the carotid. So I would open that next. I would try to dissect on the front of the carotid artery, just carefully using suctions. If this tumor doesn't suction off, you're not going to be able to get a good resection of it. It's when you get these growth hormone secreting tumors that are very fibrous, they are completely stuck to the carotid artery. I've had one of my worst carotid injuries trying to dissect one of these. But if it's suctionable, which it probably is, then you can remove that and then work towards the posterior compartment and the superior compartment, which is the one that takes you right there to the oculomotor triangle. So the cella first, the anterior compartment of the cavernous sinus, and then finally behind the carotid artery to work through the oculomotor triangle. Now, if you can identify the third nerve and stimulate the third nerve to understand where it is, then you can cut the interclinoidal ligament between the anterior and the posterior clinoid, where it sits just below the third nerve, and that opens up that oculomotor triangle that much more and gives you more room to work. That then allows you to follow the tumor through the oculomotor triangle, which seems almost impossible. But again, you're not making an opening into the middle fossa around the carotid artery, you're following the tumor. Again, it's putting the endoscope into the surgical cavity. Now you would have the endoscope in the cella, looking out into the oculomotor triangle, and just with 2 suctions following the tumor.
Okay.
The truth is, if you don't successfully get that portion that goes through the oculomotor triangle, anytime you leave tumor behind, you have to be prepared for it to undergo apoplexy, for it to bleed. If that's in the suprasellar space, it's a problem because patients can go blind. If it's lateral here, it may bleed and be completely asymptomatic. The only problem in this case is that you would have residual growth hormone secreting tumor. But I think you could get a pretty close to a complete removal here, although I think this patient is probably incurable of their acromegaly when the tumor is that invasive, but you can get pretty close. It's a very challenging case.
Okay, thank you. I think it's time to Calvin to present his case. Calvin?
Yes, hello. Yes, hi everyone. Hi, Professor Gardner. I'm from Hong Kong and really appreciate to have this opportunity to join this wonderful webinar and really enjoyed the presentation by Professor Gardner very much. So I'm going to present my case. Okay, can you see my screen here?
Yes.
Yes, okay. Well, yes, I'm from Queen Elizabeth Hospital from Hong Kong, and actually a few of my colleagues actually have joined this webinar as well, all the way from Hong Kong. It's what time? It's 11 in the evening, so good evening. And so I'm going to present a short case on the tuberculum sedimentangioma, and like to have, of course, the opinion and comment from Professor Gardner. So to start off with, it's a patient with a poor vision, 65-year-old gentleman with a visual deterioration for 3 months. And this is the visual field that showed that the left eye is quite severely affected with a VA of 0.1. The right eye is also affected, 0.5. And the OCT was done by the ophthalmologist, showed the left optic nerve thinning. Hormonal profile was normal. So this is the MRI, the T1 contrast MRI. You can see the axial, the sagittal and coronal here. And it's not a very sizable tumor. We think it's quite a nice case to start off with for endoscopic approach. And the only thing is that you can see that there's a small superior extension here, which actually elevates the optic nerve, the optic chiasm, and is very close to the ACA as well. This is the T2, as you can appreciate also both the AGs here. The optic chiasm is stretched from below by the tumor. And the good thing for this case is that it does not really extend a lot to the both sides of the carotid nor the cavernous and the sinus. At least this is what we think preoperatively. So this is the CT. We routinely do a CT paranasal sinus for navigation as well for fusion. And it's quite pneumatized paranasal sinus with greatly pneumatized natural recesses, and actually both Vidian canals can be visualized well here. So we think should be a nice case for endoscopic and nasal approach. Would you agree, Professor Gardner?
I mean, beautiful sinus anatomy makes it very favorable. I don't think that lack of that is a contraindication, but certainly having that big Onodi cell there, you have to be careful, but that would be absolute beautiful anatomy. The only concern I have with this case is that extra lobule that you pointed out. And it's both, you have to be aware of it, but also when you start to see that pattern of those multilobular tumors, it can be a sign that the tumor does not have a nice arachnoid plane. It has broken through the arachnoid plane. And so it may have some, maybe a sticky tumor. That's the only thing I would say about that, is those little lobules like that can be a sign or a warning of a challenging tumor. But other than that, it's really ideal. I think personally, people like to say that this could be done through a terional, but if you look at how low the tumor goes into the cella, how sloped the tuberculum is, how tall the tuberculum is, to try to reach down there, it would be relatively blind, and you would not be able to resect that dura of the tuberculum, which extends all the way down to the diaphragma. So I think this is, I really think this is much more favorable for endonasal than craniotomy.
Thank you. Great advice. I also agree that the lobule here actually wears a bit as well. And it's actually, I would say, it's among the first field that we did from the endoscopic approach. So this is the video that I want to share. What we did, we do it with a 3D endoscope, which we think it's quite useful, and it gives the extra edge of a 3D sense of depth and perception as well, and it aids in the dissection as well. So it's the usual approach that we approach from ostium to ostium, and a binostrual approach, 2 surgeons and 3 to 4 hands. And we start off with a 0 degree, and afterwards we use a 30 degree. And we use a drill just now, and it's a bit quick. And this is the Carrison Ronger. We continue to drill it off. We used a sonopet to remove part of the bone of plenum as well. This is the intercavernous sinus, and it's a malleable section. We find it's quite useful as well. And this is the medial OCL that Professor Gardner has mentioned for the wide intercarotid exposure. That was the right side, and this is the left side. And we use navigation to check the position. And then we open up the dura using the H-shape fashion. Professor Gardner, how do you open the dura for suprasellar meningiomas?
So I open it differently for craniopharyngiomas than for meningiomas. If you want to pause for a moment, because this is a nice video. Sure. But and it's a good, perfect view right here. So for a craniopharyngioma, they're based on the stalk. And so I open directly across the superior inner cavernous sinus, where I make a little opening in the sellar dura, horizontal, and a small one above the superior inner cavernous sinus. And then I coagulate or pack off the superior inner cavernous sinus and go directly through that superior inner cavernous sinus. As opposed to a meningioma, I do more what you did here, where I open into the suprasellar space above the superior inner cavernous sinus, and I save the diaphragma and superior inner cavernous sinus for last, because it's just not as important, and it's easier to see things like the hypophyseal once I've debulked the tumor. Now, I probably wouldn't open quite as high as you did, and I would tend to open more lateral towards the falciform, which you did here. But yes, I do a similar opening to what you've done there, and then debulk the tumor first.
Okay, so if you, for the craniopharyngioma, you open directly at the superior.
Directly at the SIS, much smaller.
At the SIS, yes.
Yeah.
So how do you control the bleeding? Do you use a surgeon to pack off, or do you use flow seal?
I do. I mean, generally, yes, but I do. If you open, again, a small opening just at above the tuberculum at the prechiasmatic sulcus above the SIS, after you make an opening below the SIS at the sella, you can actually coagulate the SIS. It is an interdural structure. You can coagulate and cut it and have very good control over it. Doesn't always work, and sometimes you have to pack it off, but I always try to do that.
Right. So I'll continue with this case. It's quite a soft meningioma. It's good for this approach, and we use a CUSA as well for the part of which is quite calcified in the core of it. So this is the very nice view, as also shown by Professor Gardner just now. This is the chiasm, and this is the pituitary gland and the stalk here. And this is the this optic nerve here on the left side, which is actually indented by the tumor. And the vasculature, nicely seen here, but it's the superior hypophyseal arteries from the left side, and here would be the ventricle, third ventricle, and then we switch to a 45-degree endoscope looking at the left side. This is carotid, and Surprising to us, actually it may not be so surprising, that from the pre-op MRI, we think there is no invasion into the left optic canal, but we found that intraop there is some invasion inside with a 45-degree endoscope, and we able to manage a complete excision with the endoscopic view. And I think that was the origin of the ophthalmic artery as well. Do you usually use a 45-degree endoscope to inspect the both parts of the, the proximal optic canal?
Absolutely, and even a lot of times, if there's a lot of involvement, when I open that optic canal, I use a 45-degree scope because I worry about exactly the location of the optic or the ophthalmic artery. Now, if you open it, you want to make sure you open again at the upper aspect of the optic canal toward the falciform ligament and not lower, because the ophthalmic can sometimes originate medially, quite often actually.
Right. And how do you find an ICG endoscope useful? Because I've never tried it before, and I wonder what your experience would be.
Sure. For here, it's mostly useful for the hypophyseal arteries. Sometimes it can help you find them initially, and then obviously make sure that they're not in spasm at the end. For tumor resection, it's useful for that. For overall surgery, the most helpful thing is to evaluate your flap at the end. If you find that your flap does not enhance well, then I'll get an MRI. And if it doesn't enhance on MRI, I'll watch the patient very closely, because the risk of having a necrotic flap, which can lead to meningitis, is very high. So understanding your flap perfusion is probably the most valuable use of the ICG endoscope.
I see. Yeah, that would be a very nice.
Yeah.
Oops. Sorry about that. Okay, so this is just about the repair. We use the we use some Surgisil inlay, and then we put some fat inside, and then we use a Duragen is an inlay as well, and then put some glue to glue it to put it in place, and of course we use the nasoseptal flap as always for the reconstruction. So
a couple of quick comments about that. There are two aspects of that. A lot of people use fat in the way that you've shown there, and there's no question that using fat to plug that defect helps lower the risk of CSF leak. But I don't use it because I've just removed this thing that's compressing the optic chiasm. I want the optic chiasm to have as much room to reperfuse and to recover as possible. And by placing a piece of fat in there, I'm partially replacing the tumor I just removed. It may not cause vision loss, but it could potentially keep them from getting better as much as possible. And then the second thing is, I think the tissue glue is best used maybe on the outside or not at all. If you put the idea between the nasal septal flap is that it be in as much contact with the patient's own tissues or with the rest of the reconstruction. The tissue glue, like fibrin glue, is gone in 2 to 3 days. It's supposed to only last 48 hours. So if you put it in between, it just creates dead space that doesn't allow the flap to heal or seal to the fat graft or to the collagen that you've placed in there. So the layer in between is not necessary. Also, and we're in the process of publishing this, we looked at 50 cases with Duraseal or Ortiseal and 50 cases without, and found no difference in CSF leak. So I think the glue doesn't matter. It adds cost and probably doesn't help. So we don't use tissue glues anymore. But the most important step is the nasal septal flap, no question.
So how do you hold the nasal septal flap in place?
I mean, all you have to do is pack it. So we put a little, we still put Surgicel around the edges, and the Surgicel gets a little bit of blood in it and sticks just a little bit. And then gel foam, you're packing it up there. I don't think it really has to stick, number one. And number two, the glues, if you ever reoperated on these in any scenario, the glue very quickly just turns to sort of like jelly. So it's no different than gel foam or any other packing that you put in place. Unfortunately, it's not like a true glue where it sticks. We like to think that it is, but I really don't think it is.
So how long do you keep the pack in place?
Alvin, please, would you mind just to skip a little bit? Because we've got
Joao
is waiting to present.
For this surgery,
sure.
1 week.
Sorry.
1 week of packing.
1 week of packing. Okay, thanks. Well, for this case, we're lucky, and we may be lucky that there's no CSF leak, and vision improved afterwards. So yeah, well, it's a
Wonderful.
CT that we
Very nice talk.
obtained after that. Thank you. Thanks.
Right.
Thank you for the
Shafik.
comment, Professor Ghana. Thank you, Shafik.
Well, a very nice cases. Paul, good to see you again. And like this time I don't have my dissection in the back. I have to figure out how to do that in my computer. And I'm sorry, I missed the first like 10 minutes of your presentation because I was doing rounds in the hospital, a bit of a messy day for me. But I'm gonna quickly show, let me just share my screen here. I'm gonna quickly show just to illustrate, like we talked about showcase of adenomas, and then I'm gonna and tuberculum meningioma. So I'm just gonna continue what was started. So this case here, I hope you guys can all see the screen. This is the case of a 73-year-old man with a history of headaches and some degree of hyposmia. So it's not that he had completely lost olfaction, but he had some decrease in olfaction. And he was diagnosed almost incidentally with this planar meningioma that you guys can see here, the coronal and the sagittal, T1 enhanced with Gatto. No focal deficits on the neurological exam, but on a space of 1 year MRI scan, he had some growth, especially towards the lateral aspect of the planum sphenoidale. Considering the growth, we discussed with him the possibility of surgical resection. And then in this case, the first question that he had for us is, okay, I understand that if we go through the nose, my olfaction, which is already not very good, can be completely gone. And we actually agreed with this, that in fact, any surgical approach could lead to a decrease in his olfaction, especially since he already had some decline. I'd like to ask you, Paul, how do you see this type of case and how you usually advise those patients in your clinic?
Yeah, that's a really good point. I think because it goes to the posterior cribriform, I think the risk of loss of smell here is relatively high. I would probably quote him with an endonasal approach as high as maybe 30% to 40% risk of loss of smell. It may be a little lower than that, but I need the patient to be prepared in this situation to accept that. The trade-off in a 73-year-old is he's already starting to lose his sense of smell, and so it may get worse naturally. And a craniotomy for a 73-year-old, in my opinion, does have a little more impact. But that's sort of the trade-off, and I would actually let the patient decide, present with them those two aspects of it. And if smell is really important to him, then I've had patients like this where then I do a craniotomy if they really want to have the lowest risk for loss of sense of smell. But you're right, with a craniotomy, it's not 0% either at all.
No, a very good point. And that's exactly the discussion we had here. And since he already was 73, he understood that his olfaction was already a bit gone. And then we decided in that sense to go with an endoscopic and to go with an endoscopic and a nasal approach at this point before the tumor would extend too much laterally where we would have problems with the resection. So this is a short video of this case here. Let's see. And this is a case that I did under the supervision of Varun Kashatri and with here at Cleveland Clinic with my co-fellow, Dennis Tang. And here, so you see, we're just drilling the planar and tuberculum. Paul already showed a bunch of those cases here. I'm not gonna waste you guys' time with this. But you see that basically—
Can I ask you, Joao, real quick, what things did you do to try to preserve olfaction? Because that posterior cribriform area obviously, is involved. It's been dissected. Because one thing you can do is try to use more of an angled endoscope, but you've really got to resect some of that posterior cribriform mucosa.
Yeah, I have to say, Paul, that like even I asked you the same question last week, which I'm gonna have to try dissect the mucosa laterally. We didn't do that. In fact, kind of like that posterior part of the cribriform here. I personally, like I coagulated some of that tissue kind of to shrink and to get that view. And I particularly still prefer working that with a 0 degree, at least on the face of the approach. But I agree with you that if you feel more comfortable with a 30, maybe you don't have to do that. So on that sense, I actually coagulated some of that. And I still have to try mobilizing that mucosa rather than coagulating it. So let's just go on here. And then I fully agree with the principles that Dr. Gardner shared of blue lining and trying to drill and expose, thin out the bone as much as possible. And here, this was all guided by near navigation of how anterior we would go. And you see drilling the planum. I'm gonna skip this a bit. This is coagulating with, this is something that I got in here, used a bit with the team at the Cleveland Clinic, is using the coagulator to coagulate this external surface of the dura to devascularize. I think you can do that with this coagulator with a Bovie, with a bipolar, the importance to devascularize that. And here doing, as Dr. Gardner had mentioned, like also opening right at the tumor, coagulating and devascularizing a bit more of that tumor. And doing some internal debulking, and let's see if the technology is going to allow. Okay, beautiful. And then after doing that, really trying to find the planes. So here using microdissectors, trying to preserve the arachnoid planes and preserve the normal surface of the brain around the tumor. You see, trying to preserve the frontal basal branches on the basal aspect of the frontal lobe. I fully agree with everything Paul just said. So with a sharp dissector, in fact, I'm a big fan of Dr. Gardner's work, so I try to replicate that. So, once that all those little vessels are preserved, you can go ahead and be more aggressive to achieve your full tumor resection. Here, as he also mentioned, like a lot of this is really getting the right exposure, the right bone work. And then after that was done, we could finally get that tumor out of there. And this is just for the video, of course. And this is the view afterwards. You see the olfactory branch laterally, and the reconstruction with fascia lata inlay and onlay. This is using the button technique. And finally, the vascularized nasoseptal flap. And I have a few questions for you, Paul, based on this. I'm going to stop this right here. For the vascularized nasoseptal flap, in a case like this, like a planomeningioma going side by side, usually you're stopping the inferior cut of the nasoseptal flap at the junction of the floor with the nasoseptum, or you're going all the way nowadays to the inferior meatal, inferior to inferior turbinate. How extensive is your flap for these cases nowadays?
You're talking about as far as releasing the pedicle itself? The pedicle
in the sense of like working the nasal floor or working right at the junction of the nasal floor, the nasoseptum.
You're talking about, so extending the flap onto the nasal floor to include the nasal floor mucosa.
Yeah.
For this particular kind of tumor, it's probably not as useful. I think you end up, when you do the flap, it has, and you extend it onto the floor, it has a little bit of a tongue, which is that floor part. And the tongue on this particular tumor is probably not as useful. What's probably more important for this tumor is that as soon as you get in front of the middle turbinate, that you sweep the uppercut all the way up to the skull base. At the level of the middle turbinate, you want to stay below the level of the olfactory mucosa. And then in front of it, what people usually don't do is they don't take it high enough. So as soon as you get in front of the attachment of the middle turbinate, go as high or even beyond what you can see with that cut. And it's that wideness that makes a difference. Now, for something like like an olfactory groove meningioma, adding that extension onto the floor helps, or for a clival chordoma where you're doing a full clivus. This tumor is a little borderline. Probably we would just do a full flap and not extend onto the floor for this particular tumor, although it's getting a little bigger in size.
Yeah, and the other question for you is, you mentioned that you would keep the packing for 1 week on the previous case. Would you do the same thing for this case here as well?
Yes.
What packing are you using?
Same thing for this one, yes.
What type of packing you use nowadays?
So we have gone more to using reverse flaps since we have these spyway devices that we can place in the nose. They protect the reverse flap, which is where you harvest a flap from one side and then you take the posterior mucosa that you would normally sacrifice on the other side, and you do a lot of posterior septectomy, and you fold that mucosa around so that the anterior septum is covered. So we call it a reverse flap. But that part on the front of the nasal septum gets in your way a little bit, but we put these spyway devices in and they help protect it. So since we've gone to doing that, the area in the back of the nose is very big. And so a balloon doesn't work as well. So we will use usually Maricells. If you have a case like this with a large defect and a very high flow defect, I think Maricells are a little more reliable. I do think you could potentially use a firm nasopore or something like that absorbable, but I think it's a little bit less reliable, and it holds pressure for a shorter period of time.
Okay, very good. I don't know if I would have time. I have a short case that is an olfactory groove meningioma, but if you're running out of time, I can stop right here. I can hear you.
I
think you're muted, Dr. Handis.
Yeah, so, sorry, Joao, but we are running out of time, okay?
No, that's fine. I appreciate it. Thanks for the invitation, and good to see you all again.
Thanks for joining us.
Yeah.
We will have now, I think it's a session of Q&A session. It's about question and answers. I don't know, Dr. Terrell, if she had some.
One question from Ronaldo Rojas Abaza asking Professor Gardner, how do you control cavernous sinus bleeding?
We used to just pack it off with not Surgicel, but with Fibrillar, with Avatine, and that was very time consuming. But I noticed this was, maybe 15 years ago, my spine colleagues were using Surgifoam or Surgiflow in the epidural plexus, so I started using it in the cavernous sinus, and I find it very effective. It is not usually symptomatic at all. You obviously, we are actually trying to embolize or fill the cavernous sinus. I'm not just trying to hold it against it. I'm actually trying to fill the cavernous sinus. I don't want to be too aggressive with how much I fill it, or it could cause a cranial nerve palsy. But I've never had that happen where I fill it too much. Very rarely, patients can get a delayed 6 nerve palsy when you've opened and packed off the cavernous sinus. I think it's from blood clot and Surgifoam swelling. It happens somewhere between 4 and 7 or 8 days. It always gets better. Always gets better. I've never reoperated on it, but that's the only thing I've seen from Surgifoam. So I find it very useful.
Thank you. There is another question from Selfie Oswari. So what would you do if you have a suspicion of vasospasm from ICD endoscope after the tumor removal in the suprasellar area?
So 2 things. We use papaverin. So we have diluted papaverin. If you can't get that, you could get verapamil or something like that, a calcium channel blocker. And I will put it diluted directly onto the nerves. And then also when I place the collagen inlay, and that's usually my first layer is the collagen, I will soak the collagen in papaverin so that it's, you can use nimodipine, verapamil. Papaverin, I think, is the most effective if you can get it. And so I soak that collagen graft that is right up against the nerves and right up against the arteries in papaverin, and then I tuck it in there. But it has to be diluted by at least 50%.
Thank you. Thank you. There are other questions. So for craniovertebral junction tumors, how far can you get laterally?
The limitations are the hypoglossal canal, really. So inferiorly, you can get at least 50% of the condyle. So you can remove 50% of the medial occipital condyle, which is what takes you to the hypoglossal canal. Now, it's a beautiful example of how complementary is an open far lateral or extreme lateral approach, because from an open approach, you can resect up to the hypoglossal canal or a little bit beyond it, but you can't get the medial part. And from a medial approach, you can resect the medial half of the condyle up to the hypoglossal canal or a little beyond it. So the 2 approaches are very complementary. So if you have a midline tumor extending out to the condyle, then you can widen that endonasal approach to get there. we just do a little release now of the eustachian tube. We used to remove it. Now I will release it from its attachment at foramen lacerum to push it down out of the way a little bit and work around it essentially.
Thank you. Another question. Professor Gardner, could you please re-explain how not to use or use the glue in the reconstruction?
So you want to think about the glue. The glue, unfortunately, is not like a true glue where it's going to make things stick together. These are absorbable. They're all designed to be absorbable. Fibrin glue is supposed to absorb in 48 hours, and the other glues maybe last for 2 or 3 weeks. If you've ever reoperated on them, they're just like jelly. So think about it like a nice packing. It's a nice, easy to put on packing, but you wouldn't put packing between the nasal septal flap and your other reconstruction. You want all of these layers of your reconstruction to sit on top of each other so that they're sandwiched between the patient's living tissue and the living vascularized flap. So I might have a piece of collagen or a piece of fascia, but they are sandwiched between the nasal septal flap and the bone or the dura or even the brain, and no glue in between there. So then the glue would only go on the outside around the nasal septal flap or around whatever your last layer is to help hold that down.
Thank you. And the last question, how are you dealing with COVID-19 and endoscopic endonasal surgery?
Great question. We did a survey to see how everyone in the world is dealing with it through our skull-based Congress. And it turns out probably what we are doing is pretty much the same of what most people are trying to do. And that is test patients before surgery and use N95 masks during endonasal surgery. So in our hospital, it is part of the protocol to require use of an N95 mask during endonasal surgery. And then we test everyone before surgery. So those are the basic things we are managing. Otherwise, as we usually would, of course, checking symptoms is probably the most important. So checking symptoms and checking fever, and then doing a COVID test within 2 days of surgery. Finally, the other thing that we've discovered, and we did some tests, which we've published in a letter in, I think, laryngoscope or otolaryngology, where we looked at fluorescent aerosol that happens during endonasal surgery. And it turns out there's actually very little of it. Because we're working through such closed cavities, there's not a lot of aerosol that's spraying out of the nose. In addition, if you keep a suction in the nose at all times, then that completely removes any aerosol. We use what's called, it detects very fine aerosols, placed it directly next to the nose when we're working in a cadaver, and had no aerosol whatsoever, as long as we had an active suction in the nose. So we're also placing an endotracheal suction, like outside the spyway device or in the nose, to make sure that we always have active suction.
Thank you. Please, the last question. What about the use of Lambert drain?
Great question. So we did a randomized controlled trial, so truly level 1 evidence to look at this. And for pituitary, we never use it. But in the randomized trial looking at large anterior fossa, like olfactory groove or large planum tumors, or for posterior fossa, clival defects, the lumbar drain made a dramatic difference in CSF leak rates. We drained for 3 days for 72 full hours, and it dramatically reduces the rates of CSF leak. For very small openings like a craniopharyngioma, even very high flow, the lumbar drain did not seem to make as much of a difference. So in those cases, I only use it if the patient is very obese or if I'm not happy with my flap. And the reason I think you can avoid it for small defects is if you have a small defect and a very big flap, then it will heal so nicely no matter what. Whereas if the flap barely reaches the edge with a very large defect, it doesn't have as much overlap.
Thank you. So we have no more questions. And if the panelists could have any comments.
I can start.
And this?
Yeah, panelists are present. We have Professor Doliva, Professor Morsley, Professor Bouaita also, and my mentor, Dr. Benafa, is present with us today.
If you have any comments, feel free, please.
I start, please.
I think we welcome to Mr. Gardner and the choice of this subject is very important to the learning and the training of our resident. The first question for Mr. Gardner is, what do you think is the best way to learn endoscopic surgery of the school base for young neurosurgeons? Start with classical neurosurgery or learn endoscopic surgery right away? And the second question, what is your experience in the surgery of the cardiophthalmic aneurysm, the different form? Thank you.
Great question. I think for training, I believe that learning both at the same time, the two skills are interchangeable, but I think it has to be enforced that the same things that the student or the resident is learning, the same techniques they're learning with a microscope, they're learning to do them with an endoscope. If they learn them at the same time, then it won't matter so much to them if they're using a microscope or an endoscope, and they'll be more comfortable with both approaches. But the problem is if they view them as very different. So you have to learn dissection the same time. So I think they should be taught together, but I think it should be reinforced that the technique should be the same, regardless of what you're using to visualize. For aneurysms, I think that medial pointing, either carotid cave, medial cavernous, superior hypophyseal, or medial ophthalmic are the best cases for endonasal aneurysm. Posterior fossa are much more challenging, posterior circulation are much more challenging and much more complicated, but those medial ophthalmic, it is always a straight clip from one nostril or the other because the supraclinoidal carotid artery is essentially in line with the nasal corridor. So they tend to be relatively straightforward, but you do need a wide exposure and you need to be very comfortable and make sure you could deal with a hemorrhage if you needed to.
Thank you.
Professeur Deliba or Professeur Boaita.
Je peux parler?
Oui, oui, Professeur Deliba, bien sûr.
Bon, écoute, Thierry, je vais essayer de parler un petit peu en anglais. Si je bloque, tu me corriges. Hein?
D'accord.
Okay. Thank you for Paul Gardner for his speech. And I have some questions. First, the management of bleeding during endoscopic approach, bleeding of cavernous sinus, and bleeding of plexus, venous plexus of clivus during the transclivus approach. Do you use bipolar and some hemostatic product for this? For the first question, I don't know. It's the second question is what do you do when we have a CSF leakage? We know that the first chirurgical time is the best time for surgery. So when you do your different technique for the management of c'est-à-dire the management, c'est-à-dire pour réparer la brèche.
So
when we repair a leak.
Yeah, how do you repair?
Yeah.
Yeah, defects.
Those are both great
the first chirurgical time is the best to repair the defect. So when you have a post-operative leakage, what do you do?
Professor Gardner, you have the floor.
Yes, I think there's a little bit of technical difficulty there, but I think I can answer the questions. The first question about cavernous sinus or basilar plexus, very good question. Again, I use morselized gel foam, broken up gel foam or Surgifoam, Flow Seal. I think it is the best way to do it. You can try packing it with Avatine, but injecting Surgifoam is best. One of the things you have to understand is you have to be comfortable that you can manage it, because sometimes if you only have a small opening in the cavernous sinus, you can't embolize it. So if you're struggling, you actually want to make a bigger opening. It seems counterintuitive, but a larger opening in the cavernous sinus to make sure you can get your injection into it is important. I inject through a suction tube that has no hole in it on the side. So just a suction tube that I can put on the end of a injection, a syringe. For the basilar plexus and the clivus, there are two layers of dura. There's a periosteal layer and a meningeal layer, and that basilar plexus is in between the two. So what I do actually is I remove the outer layer a lot. I open it very widely all the way out toward Dorello's canal, and then I pack it off once, because if you only open it one time, every time you open dura more, you have to deal with that bleeding. So I strip the periosteal layer very widely and I pack it off with Surgifoam, and then I have only the inner layer that I can open very nicely. As far as a leak, one of the important things when a patient presents with a postoperative leak is we believe in operating very early. A lumbar drain usually does not work, and if it does, you have a higher risk of meningitis. The patient may be in the hospital longer. We take them back. If a patient is leaking, we reoperate on them immediately. We explore first and see where the leak is coming from, and see, is there something technical we did wrong? If we leave a piece of mucosa behind, maybe we put too much glue or something in there, and then we will, if we have to, we'll take down the entire reconstruction and redo it. But if if it's say a week or two after surgery and most of the reconstruction is very nicely healed, then we'll see, is there a way I can put some fat, or I can make the flap, or I can re-rotate the flap, or I can move the fascia so that it covers that area of leak so I don't have to take everything down. But if that fails, you've got to take everything down and just redo the reconstruction. I hope that answers the question, but I always re-explore quickly and early. Try to find the site of leak first, avoid completely redoing the reconstruction, but if you're really not sure, just redo the whole reconstruction.
Thank you.
Thank you, Mr. Gardner, for your presentation. I have two questions. The number one, what is your experience with esthesioneuroblastoma with endocranial extension? My second question is, what's your experience with frontoethmoidal meningoencephalus?
Did you get the question?
I'm afraid I didn't hear it.
So there are two questions. The first one is about what's your experience about esthesioneuroblastoma with cranial extension? And the second question is about frontoethmoidal encephalocele.
Sorry, what's the second one?
Experience about frontoethmoidal encephalocele.
Great questions. So esthesioneuroblastoma, we are able to handle only endonasally in probably 85 to 90% of cases. The only ones that we can't are if there's a margin that extends over the orbit or into the orbit, over the orbital dura, that might require an open approach. And then technically many of them, if they have intracranial extension, we can't use a nasal septal flap if the nasal septum is involved. Instead, we would just resect only the frontal sinus. So don't do a big bifrontal craniotomy, only resect the frontal sinus, take off the anterior plate, make sure your margin there is clear, and then we can do the further resection and pericranial flap for vascularized reconstruction. So we probably use pericranial flap in half of our cases. If we use nasal septal flap, we always take in a margin along the superior edge to make sure there's no tumor in the contralateral nasal septal flap. And if there is extension to the frontal sinus, or if there's extension over the orbit, we'll make a small opening, take off the anterior table of the frontal sinus to get margin and to bring in a pericranial flap. We've had very good success with that. Dr. Snyderman is waiting until we have 5-year follow-up on everybody to present the results, but we've got excellent results with intracranial extension. For frontoethmoidal meningoceles, those are really excellent cases. They're one of, I mean, it depends on the size of it, obviously, but the goal there is to reduce the meningocele. It's usually an extremely small opening, even with a big meningocele, unless it's congenital. So in children where it's congenital, you can have a very big defect, and there we just want to cover it. But in adults, it's usually a very small defect where the brain or the meninges have squeezed through, almost like toothpaste or something coming through. And then you want to amputate it and reduce it to the very small defect. And then many times you only need a free mucosal graft, and then make sure that you treat if they have intracranial hypertension. Those are both very, the meningocele is what we would consider a level 2 surgery, very good surgery to start with. And an schizoneuroblastoma with intracranial is much more challenging, level 4.
Okay. So I think Dr. Bennafa wants to put some comments.
Yes.
Can you activate your sound? Bennafa.
He's muted, I think.
You hear me now?
Yeah.
Yeah. Thank you very much, Mr. Gardner, for this amazing and nice lecture. I introduce myself. I'm Dr. Tawfiq, MD in Neurosurgery Department of Lamine de Barine Hospital University. I'm doing my thesis about the petroclival region tumors. I don't know, Dr. Tariq, if I can share short cases. Is there is a time or I?
Depends. It depends.
It depends of the time. Yeah.
Yeah.
So okay. So very much. It's about chordoma cases of the upper clavicle part with the extension upper and posteriorly, and with the small extension to the cellular region.
Nafa.
Wait.
Doctor, are you sharing your screen?
Yeah.
We can't see your screen.
Yeah. How I do the sharing, I don't know.
It's at the bottom of the link in the green. It might say show screen down where participants and chat and everything is.
How I do, Dr. Handis?
Partager l'écran en bas.
Partager l'écran.
C'est court, j'espère.
Non, c'est très court. C'est très court.
Partager l'écran en bas, c'est vert.
Partager l'écran en bas. J'ai pas l'accès.
You can just ask your question, but not.
I think for that area that you're describing, though, where the tumor does extend laterally, one of the keys, especially at the superior clivus, is the pituitary transposition, where you open the cavernous sinus, the medial cavernous sinus, you identify the inferior hypophyseal, even sacrifice it, and that gets you direct access into the cavernous sinus. You can then follow it down all the way to the petrous apex. Also complete, like you would do with the sella, and skeletonize the carotid artery to gain access to the cavernous sinus. The same thing's true for the petrous apex or the petroclival region. If you skeletonize the paraclival carotid artery, remove the lingual process, all the way down to foramen lacerum, we can then work behind into the petroclival region. And also more recently, Dr. Snyderman developed the contralateral transmaxillary approach. Rather than a transnasal, we come from the contralateral maxillary, and that gets you perfectly in line with the petrous carotid and allows us to work behind it and remove most of the petrous apex and the base of the petrous bone through a contralateral transmaxillary in addition to endonasal.
Thank you very much.
Yes.
Thank you, Mr. Gardner.
Cyril, do you want to say something?
Can I make a comment or a question?
Of course.
Okay.
Yes. For the pituitary transposition, I've never tried it before. What I did before for removing the posterior clinoid is using an angled endoscope from below and use some angled instruments to remove the posterior clinoid. Now, I know that some cases might be okay, but some might still need a pituitary transposition to that. What is your rate of pituitary dysfunction after sacrificing one part of the connection between the pituitary gland and the carotid?
Yeah, great. So what he's referring to is the inferior hypophyseal artery sacrifice. So the gland itself has superior hypophyseal and inferior hypophyseal. The superior hypophyseal comes at the distal dural ring and the supraclinoidal carotid. The inferior hypophyseal comes off in the cavernous off the meningohypophyseal trunk. You can sacrifice the inferior hypophyseal on both sides and not lose pituitary function. The majority of the gland vasculature comes from the superior hypophyseal. So if you only sacrifice the inferior hypophyseal, we studied this recently and presented it. We, out of our series of something like 30 or 40 cases, we only had 2 cases of diabetes insipidus. And I think that was from direct manipulation of the posterior gland and not from the inferior hypophyseal. So you do not lose hormonal function from sacrifice of the inferior hypophyseal. I think it's a safe thing to do. And I think you can do it easily to gain more access to the posterior clinoid. The anterior gland, if you look at it from a transposition, has a nice layer of dura over it. The posterior gland does not. That dura does not extend over the posterior gland. It only has its capsule. So you do have to be careful when removing the dorsum and the posterior clinoids that you don't damage the posterior gland directly. But the inferior hypophyseal artery sacrifice can be done safely. And we published that, I think, last year or 2 years ago.
So please, Dr. Gardner, I've got just one question. Which technique of pituitary transposition is less harmful for the pituitary gland? The interdural or the extradural one? I think
potentially extradural is less harmful, but the problem is with extradural, you can only do it if there's a very small posterior clinoid, and you cannot see the carotid artery to safely dissect it free. So my concern is less about the pituitary and more about the carotid artery. You know, the posterior clinoid has ligaments that attach to it that can be calcified. The posterior clinoid has dense ligamentous attachment behind the cavernous carotid artery. If you don't release those and dissect those, you can definitely get an injury to the carotid artery. And that would be almost unfixable in that location. I think the extradural and intradural are very similar in how much pituitary manipulation you have to do, but I think the interdural or transcavernous is safer.
Okay.
I would not do intradural. Intradural, where you completely lift it out, will cause dysfunction, but interdural, transcavernous is much safer.
Okay, thank you. Terelt, I think it's...
Dr. Handis.
Ouais.
Dr. Handis.
Oui, c'est de libre.
Oui, une autre question pour Paul Gardner. Paul Gardner, do you continue to practice open craniotomy for the same lesion? And what do you think if the surgeon don't have any surgical means to perform bestly the endonasal approach? Is not more interesting for the patient to practice open craniotomy?
So yeah, you're referring to, so first of all, half of my practice is open surgery. I know we have a reputation for endonasal surgery, but I only do skull base and vascular surgery. At least 50% or more of my surgeries are open surgeries, retromastoid, far lateral, orbitozygomatic, pterional, etc. So I think that for a fully developed skull-based program, you have to be able to do both. I do think endonasal covers a lot of surgeries, but I think that if what you're referring to is a case-by-case selection for the particular patient. And I think you have to be aware of your own learning curve and very slowly progress. And absolutely, if you're not comfortable or don't have the right tools or the right team to do an endonasal surgery, then you should do what is best in your hands for that patient in front of you. No question about that. But I think you should also constantly challenge yourself to slowly move through your learning curve for endonasal surgery and to develop a team. It takes a lot of patience and it takes a lot of commitment to develop a team to do these. But on a case-by-case basis, your first surgery should not be an olfactory groove or a chordoma, or these are very challenging cases. Starting with pituitaries makes sense, and continue doing craniotomy for the rest of the surgeries until you're comfortable moving forward. And everybody has a different learning curve and a different case selection for that.
Last question, Dr. Handis, please. Dr. Gardner, is about the chordoma, about proton therapy, prothrombin therapy, about chordoma. If you use dogmatically with each cases or cases by cases, what's your
great question. So I use it for the majority of cases, but we found about 20% of cases we look at FISH, so fluorescence hybridization, and found that if patients had very low rates or almost no rates of homozygous deletion of things like 1p36 or 9p21, and this was published, the lead author is Dr. Zenonos, Z-E-N-O-N-O-S. And we found that about 20% of patients have extremely good prognosis if they have not a very deleted tumor. And so for those cases, I do not use proton beam if I get a complete removal. I think it is not necessary. But most cases, if I don't have a complete removal, or if it is a highly deleted tumor, then I will use proton beam.
Okay, thank you.
Thank you.
Yes.
We have to close the session.
I think it's,
So Morsley or Professor Souad Bakhti.
Professor Souad Bakhti, please.
Oui, Professeur de Liba. Yes.
Just for the case presented by Dr. Handis, I think the younger age of the patient and the condition of practice endonasal approach for this lesion, I think that for this patient, the open craniotomy is better to remove the maximum of tumors. And
I agree with you.
Well,
okay, we will consider your thoughts, Professor Delib.
Okay.
So
it's time to end up.
Professor Morsley, could you please give
Professor Bakhti,
some words for closing the session? Professor Morsley.
Okay.
Yes.
We thank Professor Bakhti and you, Dr. Terelt, for this, for your, excuse me. For this presentation of Dr. Gardner, very interesting topic for the young neurosurgeon in the learning of the neurosurgery, the best neurosurgery, the future neurosurgery. And I think that Mr. Handis and the young neurosurgeon of Hong Kong and United States, the surgery of the skull base, the anterior skull base, as is very interesting to learning the anatomic. The approach, the microsurgical approach or the endoscopic approach are complementary to explain the way of the result. So I thank secondly Mr. Gardner and our friend from Hong Kong and from United States. And thank you, Professor Bakhti and Dr. Tevfik.
Welcome.
Professor Bakhti, could you say something?
Yeah, some words?
Yeah, to end up. Yeah, you are muted.
You are muted.
Can't hear you.
Unmute, please.
Just again to say thank you to Professor Gardner for his outstanding presentation. I think that everybody has learned a lot today. And thank you also for the young neurosurgeons that have presented very interesting cases that have led to a wonderful discussion. And so I hope that we will have also other webinars in the future with many, many topics of neurosurgery. Thank you to all of you.
Thank you, Dr. Gardner.
Thank you. Thank you.
And thank you very much for having me.
Okay, bye-bye.
Thank you, everyone.
Thank you.
Thank you very much.
Bye-bye, Calvin.
Thank you very much.
Bye-bye.
Bye-bye.
Bye-bye, Professor Gardner.
Thank you.
Thank you, Ben Nafa.
Thank you, my friend. See you.
See you.
Bye-bye, Shafiq.
Bye-bye, Calvin.
دكتور بالنفع
اهلا سي بنيبه.
وش رايك؟
والصحة.
تمام. وش رايك يا صاحبي؟
وشاكم طيبة.